Good morning, everyone. I think for sake of time and for Jum'ah prayer, we will get started just to remain on time. I'm Dr. Musa Al-Malki, consultant endocrinologist at King Fahd Medical City in Riyadh. I'm very excited and honored to chair this session. I'm here joined by my colleague, Dr. Hilal Al-Maslahi, endocrinology consultant at the Royal Hospital in Oman. I would like to welcome you all for coming over to this session titled the Adrenal Clinical Practice Symposium. We are going to have three presentations I'm sure it will be very interesting and we hope you will enjoy it. We will have time for question after each session just to save time for Jum'ah prayer. I am very pleased to introduce our first speaker. Our first speaker is Professor Paul Stewart. He is a professor of medicine at the University of Leeds. He received his medical degree from Edinburgh Medical School in 1982, and he was awarded postgraduate MD from the same university in 1988. Professor Stewart's clinical expertise including management of pituitary and adrenal disorder, endocrine hypertension, and reproductive medicine. He has published more than 400 original research articles, and currently he is editor-in-chief of the Journal of Clinical Endocrinology and Oncology. Professor Stewart going to talk to us about medical management of Cushing syndrome. Without further delay, Professor Stewart, the floor is yours.
Well, thank you, Dr. Al-Malki, and nice to meet you all, and thanks to the organisers for giving me the opportunity to return to the Gulf. I think this is my third GAAD visit, so it's great to catch up with many old friends, not that they're old, but old acquaintances, and some new. So many thanks. So these are my disclosures. So what I'm going to do this morning is really focus on medical therapy for Cushing's syndrome. And in doing that, obviously, the definition, which you'll all be familiar with, is basically a constellation of clinical symptoms and signs, which is brought on by an inappropriate exposure to chronic levels of hypercortisolism. And we divide that into, obviously, exogenous and endogenous, more about exogenous later. But if we look at exogenous Cushing syndrome, then the biggest cause of that, of course, is pituitary-dependent Cushing's disease, ACTH-dependent, but there's also ectopic ACTH syndrome and adrenal forms of the disease. And most of what I'll be addressing today actually relates to pituitary Cushing's or Cushing's disease. So if you think about how this sits in the clinical treatment of this, then as we know, the mainstay for Cushing's disease is surgery and must remain surgery. But as we all know, there are people where surgery is ineligible, people who might be elderly, people who might have significant comorbidities, people that simply don't want surgery. And there, I think medical therapy alongside radiotherapy and bilateral adrenalectomy offers a very, very sensible alternative. While surgery is effective in around about 90% of patients with a microadenoma, we know that that rapidly falls in patients with larger tumours. So when we come to look at the medical management then of people who don't go into remission, again, medical therapy is a very suitable alternative that can be in isolation or can sit alongside, if you like, a bridging therapy as you wait for the effects of radiotherapy and adrenalectomy to take over. So those are really the four indications. The other one I should have mentioned, of course, is to treat life-threatening complications of hypercortisolism pre-surgery, and there we do need an awful lot more data to provide an evidence base. So these are the four main indications for medical therapy. What you see in this slide is what's currently approved in terms of the landscape for treatment of Cushing's disease, broken down into steroidogenesis inhibitors, pituitary-directed agents, and glucocorticoid receptor blockers. And what you see here shown in brown are those that are approved by the FDA for license in the US, either in the closed circles for Cushing's syndrome, open circles Cushing's disease, and then in blue those that are approved by the EMEA for the use in Europe. So let's delve into a little bit more of these in detail and begin with adrenal-directed therapy, which predominantly, exclusively in fact, are the steroidogenesis inhibitors. And here you see there are effectively two classes. There's the ketoconazole and its enantiomere, levoketoconazole, which, as you see, inhibits steroidogenesis across several pathways in the adrenal cortex, particularly some of the early pathways. Note that these compounds also inhibit the production of androgens, which might be beneficial in women, but sometimes deleterious in men. And they also inhibit the final pathways of adrenal steroidogenesis, where we have the more selective 11-beta hydroxylase inhibitors inhibiting the final pathway of cortisol production, metyrapone and osilodrastat. So let me tell you a little bit more about the evidence base for their use. So ketoconazole has been known about for years. In fact, I was using it as a junior doctor many years ago. It has to be given 2 or 3 times daily. It's got a short half-life, usually starting doses somewhere in the region of 200 milligrams BD, up to 400 milligrams BD, and then TID. The efficacy has been evaluated largely in retrospective studies, where there's around about a 65% initial response, but something like 23% escape from that. So the response is around about 50%. But it is associated with significant side effects, and sadly, I had a very tragic case early in my training where we actually lost a patient with liver failure secondary to ketoconazole, and those things do shape your onward practice, and I'm afraid I've never prescribed this since. But the side effects are there. As I say, it can cause hypogonadism in men, but as I say, that may be advantageous in a woman with Cushing's and co-secretion of glucocorticoids and androgens. So levoketoconazole is in many ways far more exciting. As I say, it's the active ingredient of ketoconazole. The dose is between 300 and 1200 milligrams per day, twice daily, not 3 times daily. And really the evidence base for approval of this by the FDA and EMEA was on 2 phase 3 trials, so-called Sonics and Logics, and they're summarized here. The Sonics trial looked at 94 patients, and basically around about 31% of those had a normal urinary-free cortisol at the end of a 6-month treatment, which actually persisted during the maintenance period. And the other study was the other way around. This was Logics looking at people that had ketoconazole and then withdrew either to continue ketoconazole or a placebo. And there you see that compared to the placebo rate of 91 patients return of their Cushing's, that was much more reduced at only 47 in the levoketoconazole group. So again, about a 50% response rate. In the PROMPT study, that was associated with improvements in clinical features. And again, the side effects here were mainly adrenal insufficiency, which were reported in about 12% of patients. And this just shows you graphically what happened to the urinary-free cortisol over time in patients treated with levoketoconazole, showing quite nicely that fall in about 50% of patients achieving normalization. And the most frequent adverse effects were GI and nausea. So it does also cause an increase in liver function, but it's far more friendly to the liver than ketoconazole. So this actually was perhaps the most exciting development in this space, which is the launch of osilodrastat. And this was a phase 3 study. You see link 4 was here. Before that was obviously link 1, 2, 3, which were largely dose-ranging studies. And this for the treatment of patients with Cushing's disease, led by Monica Godella's group in Brazil. And what you see here is that although there was a wide-ranging dosing initially, the mean dose of osilodrastat used in these studies was 4.6 milligrams per day. and that dose titration is really important here, and particularly in your practice, because Asian patients are particularly sensitive to this therapy. So although that mean dose of 4.6 milligrams was true in Caucasians, it's actually quite significantly lower than that in Asian groups. So dose titrate very carefully, starting certainly with 1 milligram per day and then increasing accordingly every 2 weeks based on urinary free cortisol levels. And these were really the very impressive data that were published. So this is by far and away the most effective medical therapy that we have, with an overall response here of urinary free cortisol of 77% being effectively cured following a silidrostat after 3 months, compared with 8% in a placebo. And notice that this was a placebo-controlled trial, so there were, at least for 3 months, these patients receiving no active therapy. So as we saw with metyrapone, there have been improvements in clinical features, though these were perhaps more well documented in this study. So you see here there's significant improvements in systolic and diastolic blood pressure, in weight, in waist circumference, and also in quality of life scores, either the Cushing-specific quality of life score developed by Susan Webb in Spain, or the so-called Beck Depression Inventory, which is more a marker of mental health anxiety issues. Again, there were side effects, and this I think is something that we'll come back to, but is a very important part of interpreting these, because it appears that the prevalence of these was quite high, some of them relatively non-specific, arthralgia, fatigue, reduced appetite, but also some of them more in keeping with what was labelled as adrenal insufficiency, nausea, dizziness, diarrhea, and low blood pressure. But I think it's important to remember, and you'll see this in your clinical practice when you cure patients with Cushing's syndrome surgically, is this kind of cold turkey that they go through as they come back to what is normal cortisol secretion rate. This is a defined syndrome. It's called glucocorticoid withdrawal syndrome. And when you look at many of these features, they're in keeping effectively with glucocorticoid withdrawal rather than true adrenal insufficiency. Indeed, there were no episodes of adrenal crisis in this cohort. That was not seen. So just to bear that in mind, these actually, parenthetically, might be good features because they indicate a normalization of cortisol secretion. So what about pituitary-directed medical therapy? Well, there's really only potentially one of those that's been approved. Well, there is only one that's approved, and that's pasireotide, and I'll show you the data on that. Although off-label, cabergoline has been used, particularly from Anna Maria Calau's group in Naples. And you see that both pasireotide in both the US and in Europe is approved for license for use in patients with Cushing's disease. So what is pasireotide? Well, it's, to be honest, its development was largely driven by the pharmaceutical company because octreotide was coming off patent. But what they noticed in the development of this, that unlike octreotide, it had a far, far higher affinity for the so-called subtype 5 receptor of the somatostatin receptor than it did for octreotide. And so this is why it's a multi-ligand with affinity for both the 1, 2, and 3 receptors, but specifically for the 5th receptor, which, as we know, is predominantly expressed on pituitary corticotrophs. So what this mechanism also involves, in addition to suppressing secretion, as I'll show you, is it does also potentially offer the ability to have a direct anti-tumor effect and cause tumor shrinkage. And I'll show you data to support that. So these were the early studies then. This was conducted back in 2012, 2011, published in the New England Journal of Medicine, showing that subcutaneous pasireotide, either given in a dose of 600 micrograms BD or 900 micrograms BD, quite nicely and effectively lowered urinary free cortisol secretion. But overall, the response rate was was modest. So what you're seeing here after either 6 months or 12 months is an overall response rate which was divided into complete or partial of around about somewhere between 30 and 40%. That was also true when subsequent studies using the long-acting preparation, which we're familiar with octreotide, so-called pasireotide LAR. This is given in monthly injections, either 10 or 30 milligrams, also had a very similar effect, with indeed very similar response rates at between, again, 25 and 40%. So it works, but it's not particularly effective. What there was, however, with that efficacy was not surprisingly clinical improvement. And I've tried to show this on this slide. What you see quite nicely here in the blue line is what's happening to urinary free cortisol concentrations. And then in the red line, the parameter being studied. And the top two are blood pressure, systolic and diastolic blood pressure, which you see fall quite nicely. Again, directly linked to the falling urinary free cortisol. Then you see lipids, both triglycerides, LDL cholesterol, and finally on the bottom, body weight, and then quality of life scores. So as urinary free cortisol is coming down, quality of life impact is going up. So impressive data then on the clinical improvements. So I said also that it had anti-tumour effects, and that's been documented quite nicely. These are anecdotal cases, kind regards of Anna Maria Colau and Andre Lacroix. But what you see here in before and after images is an obvious reduction in the size of these pituitary tumours. And when you go on and formally quantify that, then these are the data you see. So broken down here in terms of a greater than 20% decrease, as opposed to a 20% increase, you can clearly see that the balance here is towards a reduction in size of the pituitary tumour, with in fact 40% of patients having that tumour reduction, and that was true for both doses of LAR in this particular study. I think the take-home message, though, is if you've got an identifiable lesion that's about 1 centimetre or over, then overall there's somewhere between about a 10 and 15% reduction in tumour volume. So tumour progression can occur, but it's it's rare, and this is having some effect on arresting the growth of the tumour. The thing which to me, I wouldn't say kills this drug, but I was very much brought up in a kind of British tradition of first do no harm, and this does harm. This actually induces diabetes, and in a patient cohort, of course, where you've got hypercortisolism, one of the effects of which is abnormal glucose tolerance, and then you go and give this drug, which actually can cause diabetes, I think we've got to look at that very seriously. But the data are pretty florid. 3/4 of your patients treated with this drug will get diabetes that then necessitates anti-diabetic therapy. And there are other features, of course, which we're well familiar with somatostatin analogues, notably nausea, diarrhea, cholelithiasis, and the like. So this is not without significant side effects. So I mentioned about the off-label cabergoline. This, again, is data which has come from now 5 separate studies. They're largely, as I say, the best experience of this is Anna Maria Colau in Naples. And I think it's fair to say that some of her very early and exciting studies in JCNM and New England Journal of Medicine haven't entirely been repeated by other workers. But what you see in these studies is that you can get some initial response to cabergoline, but by the end of the time you're in long-term follow-up, that's fallen off to around about 30%. And note that the doses used here are really very large. So compared to the kind of prolactinoma dose of 0.5 milligram per week or up to 3 milligrams per week here, which we know has additional side effects as well. So I've personally never had the opportunity to try this. I've no personal experience, but I know that others, when they have tried it, have found it not to be particularly useful. The final licensed therapy is mifepristone. This is actually a compound we've known about for many, many years, largely as an abortion agent, because it was originally developed because it blocked the progesterone receptor. But as we know, those two receptors are highly homologous, and not surprising that it also blocked the glucocorticoid receptor. Indeed, it's got an 18-fold higher affinity for that receptor than cortisol itself. And as I've shown you in an earlier slide, is approved by both the FDA and EMA for approval in Europe, largely to treat patients with very severe, very florid Cushing's, where there's an urgent need to treat, who also have hyperglycemia. So that's the niche area in the approval regulation for mifepristone. It's a once daily dose, comes in 300 milligram tablets. There's been one open label phase 3 study which has shown significant improvement in clinical features, but there are adverse effects with this because, one, you can't measure anything. You know, obviously you're giving a glucocorticoid receptor antagonist, so cortisol becomes very, very high, and that cortisol can cause additional mineralocorticoid side effects, and because you're blocking the progesterone receptor, certainly in premenopausal women, it can cause issues which might be of concern, endometrial hyperplasia and vaginal bleeding. So it's got a niche indication for severe Cushing's with rapid control of hypercortisolism and glycemic action. So that's what's approved. I have to say this is a rapidly evolving field, and you'll see that there are many things in the pipeline. So based on a combination of preclinical, largely rodent-based studies and early clinical studies, the various things have been looked at, including retinoic acid antagonists. This is perhaps one of the most exciting, which is chimeric compounds that dually have ligand activity on the D2 receptor, as well as the somatostatin type 2 and type 5 receptors. EGFR inhibition has been shown to be effective on the basis that this is highly expressed on corticotrophin receptors, on corticotropes, stimulates POMC secretion. Cyclin-dependent kinase inhibitors, roscovatine again has been trialed in this mainly in preclinical studies. We've got here manipulation of the heat shock protein. As you know, the glucocorticoid receptor binds to this before translocation to the nucleus. It actually prevents DNA binding. So if you could interfere at that level, that holds some hope. But so far, there's been really limited results in terms of using silibinin to look at that. And then the final thing, which again is potentially the most exciting, is small molecules to target the adrenal action of ACTH in terms of ACTH receptor blockers. And I know several biotech companies that are looking at that. So let's just pull all this together then in terms of where we're at. As you see, there's no shortage of medications here to treat Cushing's disease, and wider than that, at least for some of these compounds, adrenal-based Cushing's syndrome. I've shown that they've got variable efficacy, but they do offer some personalized approach. So, for example, pyrazotide you might consider if you've got someone with a large invasive pituitary adenoma and uncontrolled Cushing's. But generally, they're all associated with fairly significant side effects. And the caveat there, of course, is I say the majority of those might be beneficial in terms of glucocorticoid withdrawal as the cortisol secretions comes to normal. But some of them definitely not, and particularly, obviously, the liver issues with ketoconazole and the diabetes issues with pasireotide. I genuinely believe that acilidrostat perhaps offers the most effective and best tolerated treatment. I think the results of that are really very exciting. It's interesting, it's a compound I was involved with for over 25 years because a biotech company from Zurich many years ago came to me saying we've got a selective aldosterone synthase inhibitor, which was indeed exciting to treat hypertension. But when I reminded them that aldosterone synthase has 97% homology with 11-beta hydroxylase, they went off and tested it against 11-beta hydroxylase, and so here it is now as an 11-beta hydroxylase inhibitor. But of course, we've been using metarapone for many, many years. Metarapone's not a nice drug to take. It's got a better side effect profile than metarapone. And what's not available in this space, particularly in our NHS, is a cost-effective analysis compared to metarapone. And it's roughly about 4 times more expensive per day. And all require close monitoring. So finally, it would be remiss of me not to have the prompt. This is just to remind you all to consider the Journal of Clinical Endocrinology and Metabolism for consideration for publishing your work. This is the most cited journal in our discipline. It's one where, as editor-in-chief, I've tried to instill a true global outreach. So of the 13 associate editors come from 11 different countries, the editorial board from 42 countries, and last year we published papers from no fewer than 48 countries across the world. So this is not a North American journal, it's not a European journal, it's a global journal. And I hope that many of you in the room will contribute in terms of paper submissions and special content material. So thanks for your time. I think we're on time and happy to take any questions.
For the very interesting and enlightening presentation, and as well for the sticking to time. We have time for 2 to 3 questions.
We started with 1 milligram a day, and that works in our experience of 14 patients with Cushing's disease. 70% of them responded immediately within 2 days. The cortisol levels were normal. And we've been able to tail that off. Of course, we treat the Cushing's disease on the way. We haven't got many of them on long-term treatment. But if I remember rightly, Dr. Amemi can remind me, one of them has been on it, a Pakistani lady, for almost 2 years, kept her in complete remission with a small dose. And we tailed the dose down as they respond. So we've had a 70% response rate with very few side effects. And I think that's something that people should continue to consider in the acute phase.
That's very interesting. For those of you who didn't hear this was a very positive experience of a significant series with cabergoline administration, again in high doses. Obviously the caveat there is you'll be looking hard at the repeat echoes of the heart. Have you noticed any issues there? No. Okay. So to bear it in mind, my experience isn't so positive, but that's clinical practice in small numbers, isn't it? Yeah.
The longest duration this patient is talking about, she's been taken for 10 years, cabergoline. For the last 10 years, she's using cabergoline, small tablet, half a tablet a week. Yeah. And in remission, yeah, the patient in remission for the last 10 years using cabergoline. And she had been infertile, and following that, she delivered the baby. His age is now 9 years.
Good, thank you.
Yes, I have.
Out of all the agents you just mentioned, pasireotide seems the only agent that can impact the size of the tumor. And it provides a little bit of hope that at some point in time you might cure the disease. But however, your concern is mainly related to diabetes. But apart from, because diabetes is very prevalent in this part of the world, and some of the patients are already on anti-diabetic medications. Is there any data that patients on pasireotide were able to achieve cure?
So I think I showed you in the pasireotide breakdown what was called full and partial remission, and full remission rates were around about 13 to 15%. So that's, if you like, and that was only obviously up to 12 months. No, like you, I've used pasireotide in patients that have got large worrying macroadenomas and have seen some modest tumour reduction, but I'm afraid far from what we would regard as cure. As I say, the problem I have with it is while you're reducing urinary free cortisol, which should be improving glucose tolerance, here you've got an agent which is actually giving you diabetes. And, I think we've got to look very, very hard at the longer term risk-benefit analysis of this. But if you're dealing with a nasty, aggressive pituitary tumour, then obviously it's well worth you considering that. I fully accept that, yeah.
Yeah, my question about this non-specific octreotide ligands. not the paclitaxel, but like lanreotide, how good they are, because our hospital has only that agent. How good it is in treatment, and it's specifically for acromegaly, but we don't have other choices. How good it's for Cushing disease. And I have a patient also, we have like middle-aged lady, she had pituitary Cushing. She went to UK where they did transsphenoidal surgery. And then that was maybe 10 years ago. Then later on she had recurrence of her disease. They did for her bilateral adrenectomy. Right now, she is having like bad Nelson syndrome. She has pituitary mass, and also her bilateral adrenal masses are recurred, like in her CT, it's showing up these masses. So for this patient, is it better to go back to the pituitary or go to the adrenal as a treatment choice for her?
Yeah, so that's obviously a very complex patient without knowing the detail. I'll come back and comment. But your first question about octreotide and lanreotide, other than anecdotal reports early on that they had modest effect, there's longer-term studies have shown that they're not effectively for Cushing's disease. So probably to the state that it's probably not worth trying. However, as I indicated, what might be exciting, marrying the two camps, is a combination of something that is a D2 agonist as well as a somatostatin receptor ligand. Let's see where those compounds come. Regarding your second patient, perhaps needs a one-to-one discussion, but my kind of dogma is always to try and attack what is the cause of the problem first, rather than its consequences. So I'm not sure what's happened with the pituitary, but again, follow-up such as gamma knife therapy and other options are something that you should perhaps consider rather than targeting the adrenals. The adrenals are the innocent bystander in all this in many ways, but it's the pituitary that you need to address. And again, rather than think of bilateral adrenalectomy, something like medical therapy with a acilabrutinib would probably have just as much benefit.
I think we have to stop here. Thank you so much, Prof. Stewart. Now we will move to the next speaker.
Assalamu alaikum. We'll move to the next talk about endocrine hypertension by Dr. Naji Alamuddin. Dr. Naji Alamuddin is a consultant endocrinologist, diabetologist, and obesity specialist at King Hamad University Hospital, associate professor in medicine and deputy head of School of Medicine at RCSI in Bahrain, and adjunct assistant professor at Perelman School of Medicine, University of Pennsylvania. He did his fellowship at the Hospital of University of Pennsylvania. He is board-certified internal medicine, endocrinology, diabetes, and metabolism, and diplomate of the American Board of Obesity in Medicine. He has an extensive research in obesity, lipid metabolism, and hypertension, and he had many publications in highly cited journals. Please, Dr. Alamuddin.
Thank you so much. Thank you, Doctor. Thank you, everyone. Thank you for the organizing committee for inviting me. I'm honored to be here among a group of distinguished guests and the audience. Thank you. So my talk is titled Endocrine Hypertension. So the objectives of the talk are to list the causes of endocrine hypertension, list the criteria for who should be screened for endocrine hypertension, review the physiology and pathophysiology of primary aldosteronism, discuss the approach to the diagnosis of primary aldosteronism, and describe the workup for other causes of endocrine hypertension. So I'll try to do that all in 25 minutes. So to start with, we'll just go over the prevalence of hypertension. This is data from the CDC that looks at the overall prevalence of hypertension, but also breaking it down amongst male, female, and different age groups. And what you could see is the prevalence is quite high. The overall prevalence is around 45%, but the prevalence increases with age. So with patients over with people over 60 and above, the prevalence is around 75%. But even in younger patients, so 18 to 39, the prevalence is quite high at around 22%. So secondary hypertension is also quite common. So 15 to 30% of patients with hypertension have a secondary cause. In young adults, those less than 40, with hypertension, the prevalence is 30%. And in children with hypertension, the prevalence is even higher at 50%. And then this is a graph from data from a study in China that looked in those with secondary hypertension, looking at causes. So you see around 63% with sleep apnea, but then around 18% of those patients had endocrine hypertension. But if you look also in this group, so those with primary aldosteronism and sleep apnea, so so the rates would be up more to around 30%. Now, before we do any workup for secondary hypertension, we just have to make sure that there are any specific medications that are causing hypertension, specifically, most commonly, oral contraceptive pills, non-steroidal NSAIDs, and many others that are listed here. Now, there's many causes of secondary hypertension, and this is by no means an exhaustive list. There's many rarer causes here that I haven't mentioned, but commonly you see sleep apnea, renal parenchymal disease, primary aldosteronism, and many others. But what's important here from an endocrine perspective is to look at those with hormonal cause for this. And you see many causes, especially primary aldosteronism, pheochromocytoma, acromegaly, hyperparathyroidism, and hyper and hypothyroidism. Now, the Endocrine Society has guidelines for screening on hypertension, and I'll be referring to those multiple times during the talk. Now, it's been almost 70 years since Jerome Cohn first talked about Conn syndrome. So he described a patient with hypernatremia, hypokalemia, high blood pressure, and had symptoms of muscular issues. Now, since then, obviously, we know a lot more about primary aldosteronism, which I'll be talking about. But what's interesting is when he described that, the patient in 1956, it was an extreme phenotype. So it was a patient who had, look at the biochemical, look at the potassium in terms of flow, how low it is, and also in terms of the tumor size, around 4 centimeters. And we've gone a long way since then, and I'll show you some data on what we're targeting now. So before we go into the details, I'd like to discuss the physiology and the pathophysiology. So from pathophysiology, what's important is that this is a renin-independent aldosteronism. So this is very different to the renin-dependent aldosteronism that we've evolved to maintain, or evolved over time to maintain our intravascular volume. So from a physiology perspective, so angiotensin II is the main workhorse here for sodium reabsorption, and it happens in the proximal nephron. Now, with primary aldosteronism, when the renin and angiotensin II are low, what happens is there's more sodium delivery distally, and then that's when aldosterone comes into play. So it interacts with the mineralocorticoid receptor antagonist, and then there's the ENaC, sodium reabsorption, and as a result, you have the hypokalemia and acid secretion. So to summarize this part, so it's a vicious cycle that leads to cardiovascular disease, and what happens is there's increased, as I showed you earlier, there's increased distal sodium delivery, increased sodium reabsorption, volume expansion as a result an increase in blood pressure. There's a hypokalemia, increase in acid secretion, and this leads to an increased risk for cardiovascular disease, which is independent of the blood pressure. So the hallmark biochemical features for primary aldosteronism are a suppression of renin and an inappropriate, dysregulated production of aldosterone. So this is referring to the guidelines on who should be screened for primary aldosteronism. So it's patients with severe or resistant hypertension, meaning those with a blood pressure of 150 over 100, or 140 over 90 on 3 medications, including a diuretic, or less than 140 over 90 on 4 or more medications. We also screen for those with hypertension and spontaneous or diuretic-induced hypokalemia, so those with hypertension and sleep apnea, hypertension and adrenal incidentaloma, hypertension in a family member with primary aldosteronism, and hypertension in a family history of early onset hypertension or CVA. Now, you might think that this is quite a strict screening, that we should be screening for more, but unfortunately, even with these strict guidelines, we're not doing a good job in screening. So this is data from a major academic center where they looked at patients who should be screened for primary aldosteronism. So in patients with hypertension and hypokalemia, only 2.7% of those were screened. And in fact, when you look at patients with hypertension on 3 medications, half of those were even less were screened. Now, when we look at hypertension and sleep apnea, it's even more, it's worse, so only 1.4%. So what we're capturing is not even the tip of the iceberg. And there's many reasons for that, but it's very, very important. And maybe the main message, if I can get out, is we should be screening a lot more for primary aldosteronism. And there's many reasons for that. Now, most of hypertension is seen at primary care. The hypertension guidelines don't really help in that regard, but it can be quite an overwhelming task when someone's thinking about screening for primary aldosteronism. So this shows you the hurdles that we face. And when someone looks at this, they say, this is just to get to removing the adenoma. So there's withdrawal of interfering medications, and then interpretation of the aldosterone-renin ratio, repeating the measurement, doing confirmatory testing, sending for adrenal vein sampling, and so forth. So this can be quite an overwhelming task. Now, going back to the guidelines in terms of what we are supposed to do and how we screen. So for patients being screened for primary aldosteronism, the main thing is to start with checking an aldosterone and a renin value. And the idea is you're supposed to have an aldosterone of greater than 10 and a suppressed renin. Now, moving forward is what we look at the aldosterone to renin ratio. And the criteria for a positive screen is greater than 20, greater than 30. And this is where I think we need to think of it differently. So here we're saying that you need a sufficiently elevated aldosterone, meaning more than 10 and a suppressed renin. So we can go with these guidelines, but I would advise not to be as strict. So let's say someone has an aldosterone as 9. Does it mean they don't have primary aldosteronism? I would move away from thinking of a dichotomous disease, meaning you have it or you don't have it, whereas it could be more of a continuum in the spectrum. So it's very important to just think physiologically, like we think of someone with hyperparathyroidism. So you can have an elevated calcium and a normal PTH that doesn't mean, it still means they have primary, means hyperparathyroidism. So this is here would be the same. So the renin should be suppressed and the aldosterone should be, if it's there, even if it's in the lower normal range, it still means that they can have primary aldosteronism. So once that meets the criteria, the next thing is to do a dynamic confirmatory test. And another way to think of it is it's an aldosterone suppression test. And there are many, many ways of doing that. So the guidelines talk about different methods. All of them work. It's really what you're comfortable in doing and what your center is used to doing, and also what's appropriate for the patient. So most commonly used would be an oral sodium loading test, where our patients in general will have a lot of sodium, so you get them to have a bit more soup, Campbell soup or Maggi soup here, have some chips, let them do that for 3 days, and then on day 3 do 24-hour urine collection. And what you're supposed to do, so you're making sure that their intravascular volume is increased, and as a result, then you check their aldosterone. So in normal circumstances, the aldosterone should suppress. If it doesn't suppress, you check their 24-hour urine sodium, urine aldosterone. If it doesn't suppress, it means confirms that they have inappropriate aldosterone secretion, and this is consistent with primary aldosterone. Now, if someone has uncontrolled hypertension, then I wouldn't do that on these patients in the outpatient setting. Another test that's commonly used is the saline infusion test. So you bring them to the daycare center, to the day center, and you give them IV saline, and then you measure their aldosterone. So you should just be careful in patients with heart failure or renal failure. But as I said earlier, all these tests work. The fludrocortisone suppression test, I don't typically use. I feel it's inconvenient, especially in an outpatient setting when you have to be doing this regularly. But they all work. Just which one you're comfortable with and what works for the patient. So once you confirm that the patient has primary aldosteronism, the next thing to do is to do CT scanning for primary aldosteronism. And this is from the guidelines, so we recommend that all patients with primary aldosteronism and undergo adrenal CT as the initial study in subtype testing to exclude large masses that may represent the adrenocortical carcinoma and to assist the interventional radiologist and surgeon where anatomically appropriate. And this is done in conjunction with adrenal vein sampling and, if needed, ancillary tests to guide treatment decisions in patients with PA. Now, there are lots of limitations for CT scans. So it has the sensitivity, the specificity isn't great. And this is data quoting, this is text from the screening guidelines, from the primary aldosteronism guidelines, where I refer to these studies that highlight the limitations of CT scans. So in one study of 203 patients with primary aldosteronism who were evaluated with both CT and adrenal vein sampling, CT was accurate in only 53% of patients. So it's like a flip of a coin. So we can't rely on CT scans to determine if someone has which side the adenoma, the primary aldosteronism is come from. So on the basis of CT findings alone, 22% probably would have been incorrectly bypassed as candidates for adrenalectomy, and almost a quarter might have had unnecessary adrenalectomy. So based on this, adrenal vein sampling is essential to direct therapy appropriate for patients with PA who have a high probability of an adrenal-producing adenoma. So what is adrenal vein sampling? So it is considered the gold standard to distinguish unilateral from bilateral disease. And it's basically a catheter goes through the femoral vein and takes blood samples from both adrenal veins and from the IVC to try to localize it. Now, there's different protocols for this, but you want to try to confirm that you're in the right position first, then you want to lateralize, and then you want to look for suppression, contralateral suppression. Now, I'm not going to go into the details of adrenal vein sampling, but there's many, many issues with adrenal vein sampling. It requires an interventional radiologist who will sample both adrenal veins and the periphery. It's a difficult procedure, and this is all from the guidelines, what I'm referring to. So especially in terms of successfully cannulating right adrenal vein, this requires experience. I remember in 2018, I was at the Mayo Clinic, and Dr. Bill Young, who's an expert at this field, I had a meeting with him, and he had patients who the day before had adrenal vein sampling. He had 4 or 5 of these patients. Their results there, so they see him, they determine the result, they go for surgery, and then the next day they're out. Now, but Bill Young is not everywhere, and we don't have interventional radiologists with this experience everywhere. So we need to keep that in mind. We need a lot of experience doing this. Where I used to work at the University of Pennsylvania, there was one radiologist. His name was Dr. Scott Tortola. He was the only one among a huge group of radiologists who would be doing this. So it requires a lot of experience. And when I talked to Dr. Bill Young about this, he said it's easy. Just get a champion, someone from the department from the radiology who would champion this and take this forward. I haven't been able to do that so far, and it's hard. And I think that's where I'll go into the next part of my talk. But even adrenal vein sampling, which we consider our gold standard, has issues. So the success rate for cannulating the right adrenal vein was 74% only. And it does have complications around 2.5%, so you can have adrenal hemorrhage, there's a high load of radiation, and it's not standardized with multiple protocols. So if you look at the literature, there's the use of ACTH. Do we give ACTH? Do we not? Do we give it as a bolus? Do we give it as an infusion? So even interpreting ABS can be challenging. So this is a randomized controlled trial. This is the only one that I'm aware of that has compared CT. It's called the Spartacus trial that has compared CT versus adrenal vein sampling. They took around 200 patients with primary aldosteronism and randomized them into 2 groups, a CT group and an AVS group. If they found an adenoma, they had surgery. If there was no adenoma or bilateral disease, then they went for medical therapy. And you had a group at the end so you had around 92 patients were analyzed in the CT group. 46 had adrenalectomies, 46 had mineralocorticoid therapy. and similar in the AVS group. Now, there's a lot of issues with Spartacus trial that we could talk about, but it is the only trial that has looked into this. And after 1 year, there was no significant difference when comparing the two groups in blood pressure, median number of drugs, potassium, and resolution. And this is, so in fact, So what the authors concluded is that there's no difference between the two groups, which is, again, we'll talk about how that might change the way we treat this. This is a study that looked at treatment outcomes with adrenalectomy. So if you look on the right, you see that from a biochemical perspective, the data is very good. You have complete success. So the way this is, we look at outcomes. These are complete success, partial success, meaning that they are using less blood pressure medications or their blood pressure is better controlled on the same medications, or absent success. So when you look at the clinical success with adrenalectomy, you have complete success in only 37% of the cases. You have partial success in 47% of the patients, but unfortunately there's 16% with absent success. So you get a patient to go to surgery and there's a high chance that nothing will change. From a biochemical perspective, definitely significant improvement, so 94% with complete success. So that's where I'll move on to next, so medical treatment. It's severely underused, it's well tolerated, it's cheap. Now these drugs can have side effects, but there are options to use, and it's important to try these. So spironolactone is the most commonly used, and if they don't tolerate it, you can try eplerenone, but you have to use it at a twice a day regimen. Now, the main issue with the use of these drugs is that we don't give them high enough doses. So we need to dose high enough so that the renin is no longer suppressed. And I think that's the main problem a lot of times, is we use something like 25 milligrams of spironolactone, which might control their blood pressure, but it doesn't control, it's not a dose high enough so that the renin levels go up. So this is data from several meta-analyses that have compared medical versus surgical treatment of primary aldosteronism, and I'm going to focus on, just so we could look at it here, so this is looking at medical versus surgical treatment, and what you could see is that the blood pressure control is very similar when we look at this meta-analysis between medical and surgical therapy. And more importantly, when we look at longer-term outcomes, like left ventricular mass, there is no difference. So it's important to keep that in mind when we're treating. So I know we've been trained over time that anyone with primary aldosteronism, we should try to do the full workup and send them for surgery. But as you can see here, the medical outcomes are quite good. So the treatment objectives of primary aldosteronism is resolution of hypokalemia, normal blood pressure, and then the prevention of aldosterone-specific progressive CKD and cardiovascular damage. So what's on the horizon? Very, very exciting. Lots of changes happening with primary aldosteronism. So I showed you the issues, the difficulties, the feasibility of adrenal vein sampling. So there's a lot of newer ways that are coming along to diagnose. So metomidate PET-CT, it's a tracer that's used that can be very helpful in localizing primary aldosteronism, and the data suggests that as of now it's non-inferior to AVS. There's other tracers that are coming that also seem to be quite good. The other aspect is metabolomics, so collecting 24-hour urines and looking at the metabolomics, trying to distinguish those with primary aldosteronism, those without primary aldosteronism. Now, with AI, this seems to be much more realistic just because of the large amounts of data that are coming with this, but this seems to be very, very promising. But then even in terms of treatment, it's no longer necessarily an adrenalectomy. So there's newer treatments that are being studied, like endoscopic radiofrequency ablation. This is a minimally invasive alternative to surgery. There's ways of stratifying the intervention by the genotype. So there's different types of genotypes, KC and J5, different ones that respond differently, and might be a way to look at this. And then there are novel therapies. So there was a study, phase 2, I think, that was published in the New England Journal of Medicine earlier this year about an aldosterone synthase inhibitor called baxdrostat, and that led to substantial reduction in systolic and diastolic blood pressure in patients with treatment-resistant hypertension. And there are many of those drugs that are also being studied. So a lot more options that are on the horizon that will dramatically change and shift the way we treat primary aldosteronism. So I'm going to move on now very quickly to talk about pheochromocytomas and paragangliomas. So again, there are guidelines in the Endocrine Society that look into screening, and the management, diagnosis and the management of pheochromocytomas and paragangliomas. So just to recap, these are neuroendocrine tumors of embryonal neural crest origins. They're often benign but cause problems for 2 reasons: mass effect and oversecretion of catecholamines and the metaphenephrines, and this leads to hypertension, heart disease, stroke, and death. Clinical presentation, what we're taught usually in medical school is the classic triad, not commonly seen. These are the headaches, the palpitations, and the sweating. You have hypertension, it could be sustained, it could be orthostatic, episodic, and relative hypertension. Other symptoms include anxiety, tremors, weight loss, flushing, and hyperglycemia. But many patients are completely asymptomatic, especially those that have adrenal incidentalomas, and that's why it's important to keep that in mind when diagnosing pheochromocytomas and paragangliomas. So why does it matter? Because, as I mentioned earlier, it can have cardiovascular implications, can cause cardiovascular disease and death, can decrease quality of life. These can be malignant, and they can have prognostic and surveillance implications for patients and relatives. So again, from the guidelines, when do we screen for pheo and sympathetic paragangliomas? So if patients have paroxysmal signs or symptoms suggesting catecholamine excess, such as palpitations, sweating, anxiety, panic, or elevations in blood pressure, headaches, and pallor. If there's provocation or precipitations of symptoms by certain medications, beta blockers, certain anesthesias, sympathomimetics, SSRIs, and SNRIs. Those with resistant hypertension, incidentally discovered adrenal mass, as I mentioned earlier, and then a previous diagnosis of a pheo, hereditary predisposition for a pheo or paraganglioma, and finally a syndromic feature indicating a pheo-related hereditary syndrome. So the most important thing is to confirm biochemically that a patient has excess catecholamines. Do not proceed with imaging prior to biochemically confirming the diagnosis. So how do we confirm that? We use plasma-free or urinary fractionated metanephrines. A normal value will exclude pheo with high reliability. Now, the problem is where we have elevated values, these are not fully specific for the presence of pheochromocytoma, paraganglioma, as I'll talk about in a bit. There are several causes for false positives: heart failure, renal failure, hypoglycemia, seated position, and no preceding rest. So ideally, if you can, draw blood samples from an indwelling cannula after a supine rest for 30 minutes. Now, unfortunately, this is practically very, very difficult to be done. If you could do it where you're working, that's fantastic. In most places I've worked, it's very, very difficult. So just when you do this test, if you order plasma metanephrines, it really depends on your level of suspicion to see it. So if it's mildly elevated, that doesn't mean that the patient has a pheochromocytoma. As I said, if it's normal, that's reassuring. If it's mildly elevated, it's unlikely to be a pheochromocytoma, especially if you had a low suspicion in the first place. But then that begs the question, why did we order the test in the first place? So if it's not feasible or you're not comfortable with ordering a plasma metanephrine and dealing with these mildly elevated levels, you could do 24-hour urine fractionated metanephrines. Now, there are many medications that can cause false positive biochemical testing. Many of these were related to assays, which now with the use of LCMS are no longer an issue. But some of these medications do cause an elevation regardless of the assays, specifically medications like tricyclic antidepressants. So when ordering these tests, it's important to get a detailed medication history to see if any of these tests can cause a false elevation in these tests. So how do we interpret them? So I worked with Dr. Debbie Cohen, who's an expert in FEOs. She told me unless the values is greater than 3 times above normal, you should really not be thinking this is a FEO. So values should be much, much, much higher. So 2, 3, 4 times above the upper limit of normal is usually what's expected. So these are excellent screening tests if they have an excellent sensitivity, but their specificity isn't as great, and that's why we should be careful when interpreting false positive, mildly positive results. So bottom line, just before I move on here, is if you have a high level of suspicion, check. If someone has a FEO, these levels are going to be very, very high. And if they're high, meaning double, triple, the next thing to do is to localize it using imaging so you start out with CTs. If you can't find something, then you move on to other more advanced imaging. For the sake of time, I'll move on and we'll talk about just renovascular hypertension. So this is usually, you suspect that in patients who have onset of hypertension younger than 30 years old or accelerated hypertension, or if someone has deterioration in renal function in response to something like an ACE inhibitor or an ARB. And that's when you would start this workup for this. And there's ultrasounds are often done. Unfortunately, they're very operator dependent. So something like an MRA would be much better if you're able to do that. So renovascular hypertension is another thing to screen for if you have suspicions. Then obstructive sleep apnea, I think, is also, as we mentioned earlier, very, very underdiagnosed. So when your patients, if you're suspicious that they have obstructive sleep apnea, make sure to refer them for sleep studies. So I will be finishing now with the summary. So just to summarize, that endocrine hypertension is quite common. Primary aldosteronism is common and underdiagnosed. So my main point is try to screen as much as, assume patients with hypertension have primary aldosteronism and then try to show that they don't have it. It really contributes to cardiovascular disease independent of blood pressure. There's recent advances in metabolomics, imaging, and treatment, which will change the approach to the treatment of primary aldosteronism. And then FEOs, plasma, and urinary fractionated metanephrines are both appropriate and highly sensitive screening tests. True positives typically have substantial elevations of metanephrines when compared to the reference range. Thank you very much, and I'm happy to take any questions.
Thank you very much, Dr. Alamuddin, for excellent talk. Now the floor is open for questions.
Dr. Naji, I have a patient who has primary aldosteronism. He has an adenoma, small one on the right side, and with hypokalemia, like severe hypokalemia. And initially he was not, there was an adenoma in that adrenal, and he was not keen on surgery. So we blocked him maximally with the aldosterone, and also we gave him potassium tablets. Over time, actually, we repeated the CT. There was an adenoma showed up on his left adrenal. We don't have expertise in adrenal vein sampling. Is medical treatment is actually, he is keen on more of medical treatment. Is medical treatment is enough, or
Absolutely.
I have to push for surgical treatment?
I would not. I would push for, especially if it's bilateral and you're not able to do the renal vein sampling. But as I showed here, medical therapy is as good. Just make sure that you're dosing with the spironolactone at doses high enough that the renin values go up. So I often check renin values on these patients just to make sure that it's not suppressed.
For the sake of time, try to be question short and specific.
Comment. We found chromogram A is very useful investigation, is important as plasma or duodenal catecholamine, as diagnosis and follow-up. because we treated many patients, and we treated them with octreotide. That's why we can see the chromogram normal before doing surgery and following surgeries.
I think chromogranin definitely is one thing to look at. The main concern with chromogranin is it could be falsely elevated, especially with use of proton pump inhibitors, and our patients are using proton pumps inhibitors all the time. So I just worry about that, but I understand, like, from a follow-up perspective, that you can follow.
None of the patients using omeprazole, so we find it very useful.
The last question from Dr. Ali Zahrani, please.
Yeah, I have actually comments, two comments. One, I think we have difficulty in drawing the line for screening versus no screening, because honestly, I think mild primary hyperaldosteronism is very common. Almost if you screen for it, you will hit the ratio, and those patients definitely have a disease. But the question then, what is the value, or what is better, to just treat them like essential hypertension, or to go farther and investigate those patients?
It's a great question, Dr. Ali. So let me tell you how my practice has changed. When I first moved to Bahrain, I was initially trying to figure out every person, trying to diagnose it with sending them to adrenal vein sampling, trying to localize. It would cost a lot of money, create a lot of stress for patients, and would eventually get nowhere because of all those follow-ups. So right now, I've changed my mindset. Is all these patients probably have primary aldosteronism? I need to be much more aggressive about treating them, so I'm much more liberal with the use of spironolactone. So I do start with checking aldosterone and renin values. If I see any suspicion, I will do one of the confirmatory testing, but often I just start with spironolactone even without that.
And if I may just make another comment about the value of AVS, I'm practicing at King Faisal, and for many years we did not have a good interventional radiologist. Now for the last 5 years we get an excellent one. And I can tell you the success rate is probably 98–99%. Wow. And I think the surgical management is extremely rewarding if you clinch a good diagnosis of unilateral disease. So I think it's advisable that everyone in a good center try to really find a good interventional radiologist, and the results are really impressive.
Absolutely, I completely agree with you. I do advocate for surgery usually for younger patients to try to get them off these blood pressure medications early on rather than keep them. But older patients, I less do that. Thank you.
The last short
Dr. Naji, I would like to hear your opinion about the use of non-steroidal, mineral corticosteroids, agents that's proved preventing chronic kidney disease, by blocking classical and non-classical effect of aldosterone, So, such as Virinone. Yes. So, and to avoid, the side effect of anti-androgenic, with the spironolactone. So do you have any,
So I know there's studies looking at finerenone specifically with this. I don't know of any data specifically, but it does make sense on how it should be used, and I think there is room for finerenone in the future, but I don't know details on that, unfortunately.
Okay, thank you.
Thank you.
Thank you very much, Dr. Alamuddin. Now we'll move to the last presentation.
Just a small announcement. We are going to have the industrial symposium by MSD for 10 minutes. Then the shuttle bus will be available at gate 11:55 for transfer for Jum'ah prayer to the Sultan Qaboos Mosque. After that, we will come back for lunch and to resume our activity. Now we will conclude our symposium by the last talk by the Professor Stewart, who was introduced already in the first presentation. He is going to talk about the chronic glucocorticoid used, how to assess and manage hypothalamic pituitary adrenal axis suppression. Professor Stewart, the floor is yours.
Thank you very much. Just very briefly on the last talk, it was a great European Adrenal Network meeting last week. The pathology, I think Conn's isolated adenoma is going to be excessively rare. When you look at the pathology and radiology, many of these have got bilateral disease, they've got more than one adenomatous lesion, and moving the dialogue, as Nahi says, to really effective, potentially monotherapy with a mineralocorticoid blocker needs to be where it is, rather than our obsession with taking something out that may or may not do the business. So that's a personal anecdote, but I think with an evidence base. Right, so I started by telling you about lots and lots of compounds for what was a very, very rare disease. This is now going to be the converse, which I'll hopefully convince you is effectively inadequate therapy currently for what is a very, very common disease. And very similar to Joe Verbalis' plea earlier, for all of you to take more of a role in the management of hyponatremia, this is an area that desperately needs you as endocrinologists to take action on. So let me tell you a little bit more about that. What I want to do is run through effectively why this happens and how common it is, and then delve into the clinical importance of this, which is effectively three facets. It's this yin-yang between, on the one hand, iatrogenic Cushing's, on the other hand, adrenal insufficiency, and on the third, glucocorticoid withdrawal syndrome, compounded, of course, in its most florid state by adrenal crisis. How do we diagnose it? How do we manage it? And what's coming in terms of future innovation? So this is where it all started. If you've not read this, this is a fantastic paradigm for translational medicine. Lots and lots of very clever people working in the Mayo Lab who from 27,000 bovine adrenals crystallized a few milligrams of cortisone, and the clinical rheumatologist Philip Hench, who gave it to patients with rheumatoid arthritis and they got up and walked. Amazing. And that was the birth, effectively, of the entire anti-inflammatory pharmaceutical company. And what you see now here is a whole host of synthetic steroids, largely on their bioequivalence compared to 20 milligrams of hydrocortisone per day. So the etiology of this is in many ways a victim of a classical endocrine feedback loop, because we all know that cortisol works within this beautiful hypothalamic pituitary adrenal axis, whereby it feeds back negatively to prevent its own hypersecretion. But that's a promiscuous effect. Any glucocorticoid will do that. So when you start taking glucocorticoids, be it orally, parenterally, intraarticular, rectally, inhalation, topical, whatever, they all have that same effect of blocking effectively the hypothalamus and pituitary, so you end up with adrenal insufficiency. And as I'll show you, the magnitude of this effect is dependent on the dose, on the potency of steroid, its half-life, its duration and mode of treatment, and concomitant medications. But the point being, as I'll show you, this affects all disciplines of medicine. This isn't just appearing in your endocrine clinic. Every single discipline of medicine has patients treated with glucocorticoids. So who's at risk? Well, there's no hard and fast rules. We all have different HPA axes. It's a very individual thing in terms of our cortisol secretion and feedback. But there are a few kind of guides. So if you're on the equivalent of prednisolone less than five days, there's no risk at all at any dose. On the other hand, if you're on 20 milligrams of prednisolone for over 5 days, or a lower dose, 5 milligrams for over a month, then you are at risk. And as you see here, a guide is that 40% will be insufficient after taking 25 milligrams for up to 30 days. And in one study, 7 milligrams a day of prednisolone was associated with long-term suppression, and that lasted for and it was those that had been treated the longest, 13 years versus 6 years, that were more at risk. So if you look at the prevalence of the size of the problem, as I say, we're not talking about a rare disease here now. I mean, I see, 1 patient per million has Cushing's disease. This is 1% of the whole population are taking glucocorticoids, and that's just oral glucocorticoids. Increases to 3% in patients over 70. The mean dose is 7 milligrams a day, with a mean duration of use for 2 years. So this is a significant burden of iatrogenic glucocorticoid excess. And if you go to inhalers, very similar data, similar numbers, in use increasing over a 5-year period from 1.4 to 1.7%, and again more prevalent in the elderly. This was a super meta-analysis conducted by my colleagues in Aarhus in Denmark, which effectively is a meta-analysis showing the prevalence of adrenal insufficiency with the take-home message being that 50% of patients taking oral glucocorticoids will have evidence of glucocorticoid sufficiency. And you see that that was also true with intra-articular, slightly lower prevalence rates if you're on inhalation, topical or nasal administration. Slightly higher in hematological malignancies versus rheumatological disorders. And the other important aspect, as I alluded to before, it's obviously a higher prevalence in those that have had treatment long-term. Long-term here was over a year, and in those that were on the higher dosage. So dose, duration dependent, underlying disease dependent, and the mode of administration dependent. But 50% for oral prednisolone is a good take-home message. So how do we diagnose it? Well, a random cortisol is pretty good. The only problem is it's only going to be rate limiting in around about 15% of your patients. The reason why I say that is if the cortisol is insufficient, in this case as predictive from a synacthin test, then effectively we know that everybody's deficient. And if it's over a certain value, these were actually on older RIAs, not LCMS values, then if it's over 350, then all those patients were sufficient. The problem being you've got 85% of the patients who are somewhere in the middle. And that's why the utility of a synacthin test is very helpful in terms of going on to add data and more of that later. So this came from almost 3,000 synacthin tests done in a tertiary referral centre. And if you go on and look further at why that synacthin test was done, who was requesting it, the bottom three columns will be familiar to you because these are your patients, those who've had pituitary surgery, new patients with or without surgery, post-operative assessment, with numbers around about, with numbers of failed tests here of around about 150 or so. What you don't see are the ones in the red box. And these are patients in your hospitals now who you're probably never seeing where others are doing these tests. And the point being that these are patients with inhaled or oral steroids. But again, if you look at the numbers that have failed the test here, then these are really, really very, very large numbers. And that's what I mean about the Jova-Bayliss analogue for hyponatremia. You need to be at the forefront of the management of these patients because many of these are actually dying and have significant morbidity and mortality, as we'll address in a minute. So the root's importance, this is again, if you look at the failed, from those failed synacthin tests, it was 55% of them were on oral steroids, a surprisingly large number on inhaled steroids. And when you went further and looked at the inhalation, which in our practice was mainly fluticasone, you see it was dose dependent. So the minute you got to what is actually the prescribed dose here of 250 micrograms BD, you already had a very high percentage with a failed synacthin test. And let me illustrate that with an anecdote. This is a patient of mine, housewife, asthma since childhood, treated with inhaled steroids, which in this case was salbutamol and fluticasone, had recurrent respiratory infections, which the respiratory team decided she needed more inhaler for, and then became progressively, increasingly tired, lethargic. And it was just fortunate that my endocrine registrar happened to be on call in an acute sector and made the link and showed, sorry, I think I made that mistake in my little, and made the mistake of, and made the diagnosis with a random cortisol of less than 20 nanomoles per litre. We went on to show that she'd got a daily, we went on to show that she failed a synacthin test with a peak cortisol response of just 32. She had a flat ACTH and actually a normal pituitary MRI. So this was definitely iatrogenic adrenal suppression. Now, the daily dose of fluticasone at the time was 2 milligrams per day. And if you go back to the formulary in terms of potency, bearing in mind the relative thing here of 5 milligrams being equivalent to 20 milligrams, and the fluticasone dose here, that the fluticasone at 250 micrograms per day, a total of 2 milligrams per day, is the equivalent of 27 milligrams of prednisolone. So we're using an awful lot of these inhalers now, and I just want you to be aware of the potential harm from fluticasone. This is an extremely potent glucocorticoid. It's the most potent glucocorticoid there is. And I show that with transactivation curves here, showing what happens when hydrocortisone binds to the glucocorticoid receptor, the natural ligand. This is what happens with dexamethasone, which we all regard as potent, 10 times more potent. But fluticasone is 10 times more potent still than dexamethasone. And it doesn't stop there, because fluticasone is metabolized by CYP3A4 in the liver, and there are many, many concomitant medications that will inhibit its clearance. What you see here is these just listed from A to O. There's a whole nother list from O to Z in terms of many, many other medications that will impair the clearance of fluticasone, and many of them in regular use. Omeprazole, atorvastatin, amiodarone, losartan, these are commonly prescribed medications. And the other one to beware of here is protease inhibitors treating HIV. This was another case of mine, HIV diagnosed in the early 2000s. She found herself on ritonavir, and because of some knee pain had 2 injections of Kenalog into the knee, and very shortly afterwards presented with features of Cushing's syndrome, but also of iatrogenic adrenal insufficiency with a sodium of 129, a cortisol response that was flat, and she had a dramatic clinical response to replacement hydrocortisone, and her axis slowly recovered. And another case in case report in one of the journal highlighting that this isn't just true for, obviously, Kenalog. This was a patient on ritonavir treated with fluticasone, again showing the before and after pictures in terms of fluticasone-induced Cushing's. So as I've tried to illustrate here, you do end up in this yin-yang between, on the one hand, excessive glucocorticoids, which, as we know, cause the classic features, some of which are actually more prevalent than Cushing's disease, some slightly less prevalent, but growth failure in children, poor wound healing, infections, the metabolic consequences, impaired quality of life. And on the other hand, adrenal insufficiency, when the patient either has an intercurrent illness and can't mount a normal cortisol response to that, or when they might be withdrawing or reducing their dose of steroids, which take the form of tiredness, dizziness, impaired quality of life, and hypotension. The key thing, obviously, is to prevent an adrenal crisis, where these symptoms then progress to a far more florid phase of hypovolemic shock, nausea and vomiting. And I've been in 3 coroner's courts now in the UK where the cause of death was clearly adrenal crisis in patients on relatively low levels of prednisolone, but who didn't have supplements to mount when they developed an intercurrent illness. So what about that recovery? Well, the recovery does occur in the majority of patients, but nevertheless, 40% will have persistent adrenal insufficiency 6 months following oral treatment. So as we see with the reversal of normal Cushing's, this can take time for the axis to recover. 20% will still have evidence 2 years later, and even 7% at 3 years. And there is a very, very small residual, for reasons we don't fully understand, that never recover. So we can minimize this by using the lowest dose of therapeutic glucocorticoid for the shortest period of time. That's an argument I'm always having with my neurosurgeons and nephrology colleagues. And then there's a taper regime where we taper prednisolone down to 5 milligrams per day. There are numerous ones of these. I personally reduce by 1 milligram every 2 weeks. And then switch, if you wanted to replacement hydrocortisone because of its shorter half-life. No evidence base for saying that. There's no studies that have looked at that. But the point is, never stop steroids quickly without doing an assessment of the HPA axis. And this, I think, is a very nice algorithm. It was a lovely paper by Alessandro Preet and Irina Bankos in the BMJ. Great review article, this, by the way, if you wanted to go away and read this. But broadly speaking, when you've got down to about 5 milligrams of prednisolone or the equivalent, then measure an early morning cortisol, and a bit like the data I showed you, if that cortisol is very, very low, in this case now these are on LCMS assays, less than 100 nanomolars, then effectively you've got a diagnosis. This is glucocorticoid-induced adrenal insufficiency. Either continue the glucocorticoid or switch to hydrocortisone. If the cortisol is very, very high, then you've excluded adrenal insufficiency, but the dilemma is you're left with this large group in the middle that might have, in this case, possible or unlikely, but nevertheless still possible adrenal insufficiency. And there I think many of us are, rather than treating those patients, simply giving them a supply of hydrocortisone to take in the event of an intercurrent illness. This is something which I'm very passionate about. The management of these must be the same for other forms of adrenal insufficiency. So what we're doing here is, and this was something, if you're not doing it already, I'd strongly advise the Gulf Association to do across all of your countries, is a standard steroid replacement alert card. This is something we've implemented now across Europe, with basically English on the front and then the language on the back. And this is shown to all paramedics, everybody in the accident and emergency department on presentation. So broadly speaking, if you can enforce the usual sick day rules, the alert cards, as I've said, regular assessment of adrenal function every 6 weeks, and just be mindful, again, for reasons we don't fully understand, bearing in mind they have an intact renin-angiotensin system, adrenal crisis is commoner in this condition than it is in other forms of hypoadrenalism. I touched on this earlier, but important to remember that the clinical symptoms here do not marry up with the biochemical abnormality. And many patients with confirmed glucocorticoid-induced adrenal insufficiency may have very, very few symptoms, other than non-specific symptoms such as tiredness and lethargy. And again, this is confounded in these patients by the underlying disease, by withdrawal from the steroids, anorexia, weight loss, nausea might be some pointers, together with skin desquamation of withdrawal symptom. But nevertheless, in all this mix, we're still missing many, many cases of life-threatening adrenal crises. And that's where you come in to be networking with your rheumatologists, your respiratory physicians, your nephrologists to raise awareness of this. Even on a call I was with international rheumatologists from the US the other week, they don't really believe this is an entity. We've got a lot of work to do. But we do need a greater evidence. We need a greater evidence on many of those algorithms I've run through. And until then, this was a great editorial in the EJE, European Journal, treat while we wait is a safe approach to avoid adrenal crisis. I think I've probably just got a couple of minutes just to update you on what's coming. And you know that one of the loves of my life is this enzyme 11-beta-HSD1, which is actually responsible for the conversion of inactive cortisone to cortisol. And one of the pioneer work we're doing at the moment is to see if that will prevent the deleterious effects of prednisolone. Prednisolone is metabolized in exactly the same way as cortisol. It's prednisolone to prednisone, as it is cortisol to cortisone, with exactly the same kinetics. So you have this interesting prospect in your patients taking prednisolone or prednisone in the US, that then can be back converted to the active hormone in key peripheral tissues, liver, bone, muscle, and obviously exacerbate the transactivating side effects of prednisolone. So the one thing we've been looking at is whether this will prevent some of those. This was a paper we published in Nature just earlier this year, work done with Jeremy Tomlinson in Oxford, where you can clearly see here that prednisolone, given, and this was just a 7-day treatment of prednisolone, 20 milligrams per day, significantly inhibited here glucose disposal and utilization, but that didn't happen when those patients were co-treated with an 11-beta-HSD1 inhibitor. So that initial effect you were seeing on being pro-diabetic was prevented with an HSD1 inhibitor, and there were other benefits as well in that study. The big thing, though, was the impact on bone. So this was a dramatic effect. One of the best biomarkers for glucocorticoids is osteocalcin. And you see that nicely here in this study that prednisolone very rapidly has a dramatic effect on osteocalcin, marker of bone formation, less so the pro-collagen, pro-peptide, and obviously has the opposite effect on a marker of bone resorption, the collagen telepeptides. And again, with co-administration of the 11-HSD inhibitor AZ4017, you could completely block that reversal. So this is now going forward in a series of trials. This is the key box here. These trials are underway where we're co-administering 11-beta-HSD1 inhibitors with prednisolone in patients with underlying polymyalgia rheumatica, with the idea that you won't inhibit the anti-inflammatory effect because there is no HSD1 in anti-inflammatory cells, but you will inhibit the transactivating side effects, the diabetes, the poor bones, the hypertension, and the like. So exciting times. Let's see what's happened. So I've got 3 minutes to the summary. Exogenous glucocorticoids are widely used and are given by all routes. Biochemical adrenal suppression is common and should be screened for in all cases to prevent life-threatening adrenal crisis. But the clinical assessment and management is more challenging. There are no guidelines at the moment. There's a significant overlap here, as I've shown, between the features of the iatrogenic Cushing's itself, between the adrenal insufficiency and glucocorticoid withdrawal syndrome, as well as changes to the underlying inflammation as you're changing the steroid dose. So this is difficult territory, and what I've merely tried to show you is guidance on effective glucocorticoid taper and replacement, but it needs to be individualized using your clinical acumen. The point being, it needs your clinical acumen and not the rheumatologist or the nephrologist, because we know that that's failing patients at the moment. Education is really important in this space, and I've also flagged with you some new approaches which hopefully in years to come we'll be able to come back and tell you about in terms of whether some of the selective HSD inhibitors have a role to play in preventing iatrogenic Cushing's. So thanks for that. I've tried to finish a few minutes early because I know there's other things on the schedule, but I'm happy to take questions if there's time.
Thanks, Prof, for the wonderful presentation and for addressing this important topic. I think we will have time for 2 questions, please.
Thank you very much. Is it me, yeah? Or you? Okay.
You carry
Thank you very much for your lovely presentation. 1 or 2 questions. What happened to those borderline cases when you measure the AM cortisol over time? And the second question that pertains to this is, does withholding a small dose of hydrocortisone in asymptomatic patients promote recovery over time or not?
So the answer is we don't have data on the long-term follow-up of that group at all. But what we do know is that there's a prevalence rate in that group of around about 6 per 1,000 of adrenal crises per year. That's some data I'll be showing tomorrow at the plenary as well. So it's not that they're not an at-risk group. It's just the fact that you flagged them. In my experience, it's not whether they've passed or failed the synacthin test that's important. The real thing is the impact that the intercurrent disease might have on these individuals. It's effectively flagged up a high-risk group who might be fine with the amount of basal cortisol, basal glucocorticoid they have on board, but they haven't yet got the recovery of the access to mount the doubling, trebling, quadrupling response of cortisol that's needed in a severe intercurrent illness. And that's when they run into trouble. So giving them hydrocortisone for that purpose, plus the steroid-alert CART is really important.
So that's withholding hydrocortisone, such patient low dose. Some people give just like 10 milligrams hydrocortisone AM. Does withholding that?
Well, I wouldn't recommend withholding it if they've got AI, but that's often enough. And I'm a fan of doing that because you then avoid a late afternoon cortisol, which isn't a particularly good thing. So long as they've enough on board for daily activity, that's fine. But as I say, it is this issue about doubling, trebling the dose when they get an intercurrent illness.
Thank you.
So patients who've been taking steroid for long years, 20 years, for example, and we try to taper until lowest dose of hydrocortisone is taken. The morning cortisol is around 150, but they double on Senectin but never reach more than 500. Would you think of stopping?
So I think we are seeing a cohort of people, particularly who've been on steroids for a long time, who for whatever reason don't recover, about 5%. Yours looks like there is some recovery in that.
Yes.
And with those numbers, particularly if they were on LCMS assays, I'd be inclined to almost try and just give them a supplemental dose of glucocorticoid to take in an intercurrent illness, and see if that's enough to then trigger further recovery of the axis. But to watch them very carefully. They may not need daily regular supplementation with those types of values.
Thank you.
Paul, thank you very much for enriching our conference platform again. Not very much dissimilar from what she describes, but I would like just to ask you whether you see a disparity in inhaled steroids user between the profile of the cushingoid features as well as the biochemical response of the adrenal. Because recently I had a young lady who's 16 was referred to me as suspected Cushing. However, she's clinically cushingoid. She has everything, including weight gain, verbal striae, hump, and you name it. But, her actually cortisol random was actually detected was around 340. And when we gave her 1 milligram dexamethasone, she suppressed actually profoundly. So we exclude other causes for hypercortisolism.
Yeah, so, just bear in mind, I see a lot of this, particularly in my own practice, of patients actually returning from India, Pakistan, where they've been given a nerve tonic or something from the family practitioner. Remember, steroids are also, they make you feel well. That's why they're used in cancer. They're kind of euphoric-inducing drugs, and so you find that there's dexamethasone, you find there's all sorts of stuff in these nerve tonics, and they come back with suppression as well. So I think it's well worth just being mindful that although they may not think they're being prescribed something, they may be taking something that's illicit, either internet or however they've come by those, just as a caveat. Your question as to whether inhaled steroids differ, I showed you how potent fluticasone is. Fluticasone, like dexamethasone, in my experience, is more prone to give you some of the skin manifestations of Cushing's, horrible striae, stretch marks. I showed you an example of that than I see with oral. But that's just one aspect that might be different.
Thanks.
I think we have to stop here. I am very grateful to our speaker for their nice presentation and for their time. It was really extremely beneficial and the learning experience for me, and I am sure for you as well. And for sake of time and for the MSD Symposium, we will conclude our session, and thank you very much for all of you.
All right. Dr. Maher Jallo, Clinical Professor of Medicine and Senior Consultant Internal Medicine, Diabetes and Endocrinology in Gulf Medical University, UAE, and faculty in the Canadian Academy of Natural Health in Toronto, and examiner for the Royal College of Physicians, MRCP. Granted his MB from Mosul Medical College in Iraq, his postgraduate board certification in internal medicine from the Arab Board, his internal medicine fellowship from the Royal College of Physicians in Edinburgh and Glasgow in UK, his endocrinology fellowship from the American College of Endocrinology, based in USA. Dr. Maher, go ahead.
Good morning, and thank you for MSD for inviting me to cover the role of DPP-4 inhibitor sitagliptin in type 2 diabetes, selection and expectation. So this is for your daily practice, that most of you use this medication but probably for the new generation, refocus is important. So this is the campus of our university, the Gulf Medical University and Thornby University Hospital. And I invited, this is sponsored by MSD. So you know that diabetes is a global epidemic, especially in our region. There is a huge number of diabetes and expected to increase by 87% in the coming 20 years. With this, diabetes constitute a major impact on the healthcare, responsible for 6.7 million deaths every year, and 3 out of 4 diabetic patients live in low-income country. We have the data from the area in the DiaCare survey about the HbA1c achievement in patients with diabetes. And the data show, unfortunately, that only 24% of patients with diabetes achieve the target of HbA1c below 7 and 13% below 6.5. This is not only this is the data for the 4 GCC country, and you can see the Oman, 55 to 65. We are in United Arab Emirates, around 70%. Not achieving the target of HbA1c. This is not only in the region, this is the panorama data. We're collecting the data for patients with diabetes achieving the HbA1c below 7 from the US and various European countries, and you can see maximally 50% achieve the target, and many countries 30 to 40%. This is a message which is we should never forget that the 2 important, the UKPDS data and the DCCT, will mention that 1% reduction in the HbA1c translated into significant reduction in the microvascular complication and also amputation and retinopathy. Individualization is clear in the guidelines for the last 10 years, and it is emphasized year after year that the patient which is newly diagnosed, which is young, long life expectancy, no comorbidity, no tendency for hypoglycemia, we should be aiming an HbA1c as lower as possible, probably below 6.5, or should be at least below 7. And we should be slightly more liberal with the HbA1c for those short life expectancy, tendency for hypoglycemia with cardiovascular or renal morbidity. Sitagliptin molecule, which is used, I think it is in the prescription of many patients, your patient with diabetes, for the last probably more than 10 years, available in the area. And just to focus, where is the DPP-4 selection in the guidelines? Let us take an example of Amal. She is a 50-year-old female. She has type 2 diabetes for a few years. Her HbA1c is not achieved the target with the current medication. She is on metformin 1,500. And this is her data that the HbA1c is 8.2. And the duration of diabetes, 6 years, body mass index 28, normal renal function, and fasting blood sugar not on target, as well as LDL 130. So question will come now, how we can help Amal to reach the target HbA1c. You know, in clinical practice, and this is so common, that patient on metformin with suboptimal goal, just probably refill done routinely in the busy clinic, not receiving appropriate treatment and not escalating to achieve the target. We face such patients for 1 year, many years, taking the same medication, same dose, and always the HbA1c not on target. So the issue came that if we want those patients to intensify, we will go for increasing the dose of metformin or preferably to add another agent with metformin. And you know that it is not clear which agent can be added. Now we have a plethora of diabetic medication, but also there is, tendency for each molecule to reduce the HbA1c. So we will see that if we can help Amal with the DPP-4 inhibitor, to achieve her target below 7. Any one of these medication can help her. There is no one correct answer. And for us, we will explore where the DPP-4 fit in the guidelines. We know the guidelines insist that all the patients should have the lifestyle modification as well as metformin as a backbone for their, although there is some age, society recognizing that it is not necessarily, but I feel it is important because it helps the patient achieve the target when most of the other alone not able to achieve the target. And it is now clear in the guidelines that we should look on the patient not on his glucose only, we should look on her cardio-metabolic renal evaluation. So if our patient is from the start, patient with atherosclerotic cardiovascular disease, the guidelines tell us go for GLP-1. If the patient with heart failure or CKD, the guidelines tell us go for SGLT2 inhibitor. But most of the patients, even if we adapt these guidelines, not achieving the target. Remember, in patients with diabetes, we are not speaking only about the cardiovascular event. We are keen also to decrease the microvascular event, which is closely related to the reduction in the HbA1c as early as possible. The percentage, probably we have initial data from the region, probably the patient with type 2 diabetes, 25% got cardiovascular disease, 40% maybe, 35 to 40% of CKD, but we have a huge sector of patients with diabetes without cardiovascular disease and without CKD. And the guidelines tell us here that for those patients to choose the second agent, choose an agent which is less tendency for hypoglycemia, as well as which can be incorporated with other diabetic medication and have an efficacy to reduce the HbA1c. And I think clearly the DPP-4 inhibitor like sitagliptin will fit closely in this approach of the guidelines. And this is studied in the composite M study when they took the patient with type 2 diabetes who was taking the metformin alone and decided either to upgrade the maximum dose of effective dose of metformin, the 2 gram, or to add sitagliptin. So those patients, the clinical assessing the efficacy and safety of initiating sitagliptin during metformin up titration. So the patient screened and within 2 weeks just received the placebo to see the adherence and then randomized to either metformin BID or the same metformin 1,000 twice daily plus sitagliptin 100. And the primary endpoint, what is the degree of reduction in the HbA1c. And clearly the data show that the 0.4% difference in upgrading the dose of metformin alone comparing to add sitagliptin. And this will help. Many patients will remain 7.2, 7.3 for a long time. With this, we're able to achieve the target below 7. Similar rate of adverse event, low rate of a drug-related adverse event, and there is similar change in weight, so there is no weight gain in those groups. So the composite M it mentioned that there is greater reduction of the HbA1c with the combination of DPP-4 inhibitors and sitagliptin, more tolerable, as well as no additional side effect. And this is coming with the complementary mechanism of the acting of the DPP-4 inhibitor and metformin. While, you know, the metformin will act on the liver to decrease the gluconeogenesis, while the sitagliptin will have the role in also decreasing the hepatic glucose output through the glucagon pathway. And we know that the other effect of metformin as insulin sensitizer on the liver, more on the muscle, and also the enhancing of the insulin secretion of the pancreas in a glucose-dependent manner. So we are target many aspects of the pathophysiology of type 2 diabetes. The data is also, so strong for the fixed combination from the beginning comparing to monotherapy. And this study will compare that, how much we are able to drop the HbA1c from category of basic HbA1c by using the fixed dose combination of sitagliptin, metformin, compared to monotherapy metformin alone. And you can see that with this also there is 0.6 reduction in the patient taking the fixed dose combination from the beginning compared to metformin monotherapy. And this is the higher HbA1c, the more reduction. And you can see for HbA1c above 11, we are able to drop 3.6 of the HbA1c. And for AML, for example, like our patient, which is between 8 to 9, the HbA1c, we are able to drop 1.6 of HbA1c, and this will probably help her to achieve the target. So the combination is more effective. Let your patient achieve the target as early as possible. Weight neutral, no incidence of hypoglycemia, and no increased incidence of side effect. Then we have sector of patient with renal impairment. And we know that those patients may be, for sure, they are the candidate for the SGLT2 inhibitor. But this is the data which is comparing adding sitagliptin or dapagliflozin for patients with diabetes and mild renal impairment. And this to compare the efficacy of HbA1c reduction versus DAPA in patients with mild renal impairment taking metformin alone. So with the screening and then the placebo run for 2 weeks, and the patient randomized to take sitagliptin 100 milligram, or DAPA started with 5 milligram, then up titrated in the 4 week to 10 milligram, and follow the patient for week 24. And with this, there is a significant reduction in the HbA1c in favor of sitagliptin, 1.6 comparing to dapagliflozin. So if your patient is in renal impairment and now he is on SGLT2 but not achieving the target, safely to add the third agent to achieve the target with the effective DPP-4 inhibitors like sitagliptin. Similar adverse event for the both line, and the fewer, discontinuation of the medication, but we know that the genital mycosis is much higher in the SGLT2 user, both male and female, compared to DPP-4 inhibitor. So in this, that the patient get a greater HbA1c reduction comparing to an effective SGLT2 like DAPA, and it is well tolerated with no additional side effect. So sitagliptin is the treatment option for broad range of patients, including early diagnosed, not achieving the target, or patient with mild renal impairment in addition to other agents, and even the elderly, because the study done, patient included up to 78 years old. no incidence of hypoglycemia. So there's an accumulated evidence to suggest, supported the long history of a clinical experience, now more than 17 years in the clinical practice of sitagliptin. And also, it is one of the most widely studied DPP-4 inhibitors, and it is available in more than 100 countries. And I think that, I mean, no clinic manage patient with diabetes, their patient not left the clinic without, DPP-4 inhibitors in, significant number of patients. We conduct a study about the adherence of the physician to the guidelines of prescribing cardiovascular or protective medication in patients with diabetes. And we included GLP-1 and SGLT2. And when we come to the background analysis, for those patients, the majority are receiving DPP-4 inhibitors, and sitagliptin is the most widely used. So Amal can be helped, rather than to escalate her metformin, to switch her to the fixed dose combination, sitagliptin and metformin, and this will help her to achieve the target below 7. Thank you very much from Ajmal.